Happy to see everyone in our discussion room, which will be dedicated to precision medicine national implementation strategies. I'm deeply honored to serve as a moderator for this discussion and presentations we're going to have. My name is Marcis Daugulis, and because of the reason that within this topic of discussion, medicine, future, and decision-making, considering the political perspective, all goes hand in hand, policy buildings, national strategies. I'm educated as a political scientist, so it will be a really interesting experience that we are blending together today what we know, what is good for the healthcare, and where the science is going in the future, hand in hand with what should be done considering the national strategies and policy building. So I'm really excited about this morning's sessions that we have, and nevertheless, this is a build-up session because after lunch, here will be a national roundtable of building coalition around the precision medicine and national strategy development. So everything we're going to discuss this morning will serve as a base, as a content for the precise steps to make to do building up the local Latvian national strategy. We are living in tectonic changes and shifts now. There is open windows of opportunities considering the policy building in Latvian healthcare. We have a new minister, not so new anymore, but still new minister, who is opening up the questions about national long-term healthcare strategies. We have definitely on the ground opening up of the huge long-term planning document of Latvian state, the National Development Plan for the next period, 10, 15 years. So important momentums seize the day. That's the motto of this session. About house rules, our distinguished speakers we have with excellent experiences to share will give 15-minute presentation each, and gonna do this from this podium. And afterwards, after the presentations we have, all of us gonna join the panel discussion where we're gonna answer the questions from the public, where we also gonna raise the questions about how move on and forward. And also our distinguished Professor Marcis Leja will join the panel discussion with Latvia's perspective. So house rules are clear. We are today, of course, working on audience and working on cameras. As always it is, it's a 21st century, cameras are present everywhere. And I'm absolutely happy to invite here on the stage with the first story and the first experience, Lene Cividanes, Head of Research and International Relations, Danish National Genome Center from Denmark. And just to go well into the vibe of presentations, welcome with applause, please.
Thank you. First of all, thank you to the organizers and thank you for the invitation to speak here today. It's a great honor. I'm already extremely impressed by this setup. It's a lot of attendees, a lot of speakers, a lot of people from all over Europe, I think even the world. So I'm really impressed. So far it's been so interesting. So I'm looking forward to share our Danish experiences with you. And then I think I also have to mention that I'm actually also for the first time in a precision medicine conference proud to tell that I'm also a political scientist, because it's always a challenge. I go into presentations with people doing scientific work within genomes and things I maybe not understand so much. But today I'm actually in my role, so that's nice. Okay, so what do I do here?
The good old question where to point, or is it
like
working?
Forward?
It
should be this one, right?
It's a team building in problem solving. No?
I would push this one, right? Mm-hmm.
Mm-hmm. Oh, and that was teaser. Okay.
Okay, nice. Okay, so I will of course tell you about the background for the Danish National Genome Center, how we implemented whole genome sequencing in healthcare in Denmark, and then I'll tell about this, we call it the smart use of national data. So all the research data, all the clinical data in Denmark collected can also be reused for research by other groups and by researchers in general. And then a bit about lessons learned, challenges, and recommendations for you in Latvia, built on our experiences. Okay. So the Danish National Genome Center's core tasks are first of all coordinating the implementation of whole genome sequencing in the Danish healthcare system. So far we have implemented whole genome sequencing within 17 different patient groups. Then we are collecting all these data from healthcare in Denmark and also for research, and we put it in a genome database, and we make this data accessible for the clinicians and from the researchers. And then we run a high-performance computer or a complete infrastructure where we collect all these data, and we also do collaborations with other registries to make sure that these data can be used even smarter. And last but not least, we have to promote personalized medicine in Denmark. So we support the Minister of Health in promoting personalized medicine in Denmark. And the Danish setup built on a long tradition of data collection. So we have a lot of registries where we register everything from medicine taken during pregnancy to death course to all blood samples taken are put into biobanks, and we have all the results in registries in Denmark. And the Danish National Genome Center and the personalized medicine strategy was a result of a political decision, so it's a complete top-down initiative, you could say, but it actually came from the researchers pushing the politicians to take action within personalized medicine strategy. So it was decided by the politicians to do a new health legislation on building up a Danish National Genome Center, and very important, a law on data reporting of comprehensive genetic analysis. So this is why we can actually collect all these data from healthcare settings and reuse them for research. So of course the patients consent to this, but they have to consent if they want a whole genome sequencing done in the Danish healthcare system. We are established as an agency under the Ministry of Interior and Health in Denmark, and our main focus is on treatment of patients. So not so much on prevention yet, that's to come, but on treatment and diagnosis, of course. And the strategy and the center has brought support from both the clinicians, from the researchers, from the Danish population in general. It's important to say that a big part of the money to establish the center and to implement this strategy actually came from a private foundation in Denmark, the Novo Nordisk Foundation. So together with the government and the annual budget, and with the regions in Denmark who are in charge of the healthcare system, the Danish Genome Center was funded that way. And then, of course, we didn't do this by ourselves. We have been looking to all initiatives around the world. We have engaged in bilateral agreements. We have done European collaborations to collect all the best practices from all over the world to build this Danish National Genome Center. And just shortly to show, it started back in 2016 with the strategy, then the law came in 2018, then we established the Genome Center, and no money from the Nordisk Foundation was given. Then we started building the infrastructure, and then we onboarded the 17 patient groups, which are now receiving whole genome sequencing as part of their treatment in the Danish healthcare system. And then now we are starting on the new strategy for personalized medicine, where we hope to be able to focus more on prevention, so pharmacogenetics, etc. And how did we do this? Well, this is the part of how we implemented whole genome sequencing in the healthcare system. Well, in Denmark, we have 5 regions. I'm speaking a bit fast because I only have 15 minutes, so I hope you understand. In Denmark, we have 5 regions, and we have 1 supercomputer where the data is collected. We have 2 sequencing sites in Denmark where all the data is sequenced, and then we have the 5 regions sending that data to these sequencing sites, and they're sending it back to the supercomputer and the genome database. And of course, we have a lot of hospitals where all this is done, the interpretation. And this is just to show you shortly the flow. So the clinician sits out there in the clinic, talk to the patient, give the informed consent, take the signature, take the sample, send it back to the sequencing site. The sequencing is done, the data is sent to the genome database, it's analyzed, and the interpretation is done, and then the result is given back to the patients. And then you can see in the middle the genome database and the infrastructure where the researchers can then access the data and use this for secondary use and do research in order to generate more personalized medicine. So this is what we call the smart use of the data. So we don't just collect this for clinical use, we use it again and again and again. Oh, now I'm moving backwards, sorry. This is not funny. Here you go. So far with this big bag of money, so to say, from the Nordisk Foundation, we have sequenced almost 40,000 Danes, and you can see the 17 different patient groups here. It's basically cancer and rare diseases. I'm not going to go into them because I think this audience is not so much into the genetic sides, but more into the strategies behind this. But it's 17 different patient groups, and it's, of course, based on the evidence we've collected from all over the world, which patients could benefit potentially from this. But we actually don't have specific evidence for these groups in the Danish system yet. And this is to show you that the governance around the National Genome Center is extremely complex. And this is also in my advice to you. We think it's so important to make sure that you include all the stakeholders, everyone who's important for this setup. So it means that, the politicians need to work together with the clinicians, need to work together with the experts, the researchers, etc. So what we did in Denmark is that we established the 3 advisory boards that can advise us, both international and national advisory boards. And we have a steering group with the minister involved and everything. And then we have down here the 17 specialist networks. And I think these are the most important part of our initiative. So these groups have experts from all over Denmark within these 17 different groups, and they decided on the inclusion criteria and how to implement in the Danish system. And well, how did it actually change the thing in Denmark? So having these 17 groups made sure that we could actually spread this all over Denmark to make sure that the access to whole genome sequencing is equal in Denmark. We had a much faster way of getting diagnosis. More patients could benefit from this, and it's been extremely meaningful for the patients to get the diagnosis, and of course increased knowledge around genetics in general, and better collaboration across the country. So how do we use this data? Well, as I said several times, we try to reuse this data for research, so the data in the genome database can be used again. And in order to get access to this data, you need approval from the ethical committee system in Denmark, and then you send an application to the National Genome Center, and then we give you access, you do your analysis at our infrastructure, because the data cannot leave our infrastructure for security reasons. It's very sensitive data, obviously, and it's patients. So the analysis can be taken out, and you can do your publications, and peer reviewers, etc., can of course access the data in our infrastructure. And this data is of course not very valuable in itself. We need to connect with metadata, we need to connect with clinical data, we need to connect with socioeconomic data. So currently at our infrastructure we have strategic partners, we work with them. So for example, the biobanks can connect the data with us, but it's all a manual process. It's doable, but it's complicated. So what we're working on in Denmark is to build a national collaboration for better use of health data, and we hope to be able to include the socioeconomic data here, and have everything in a federated way, where we have a hub at our infrastructure, and then we can connect and do federated analysis. And this is of course also what many of you would think, okay, this is the European health data space. And yes, this is step 1 for us in Denmark to establish the one point of entrance for the European health data space. But we think, you can see down in the, must be left corner also for you, yes. You can see like all the registries we have. So connecting all these data together with genome data and socioeconomic, at one point in the future you will simplify being able to push a button and get all the data on one individual and be able to do the diagnosis much faster. So what did we learn by doing this in Denmark? Well, first of all, we have a lot of challenges, of course. I mean, we have shortages of interpreters, doctors, bioinformaticians, as I think all countries in the world are basically experiencing currently. We did, while implementing, have an increased response time, which for some clinicians have, of course, patients even worse, shown a problem, but we're now back, and we're having shortened increased time again now. So we are still missing a national variant database. It's a bit complicated due to regulation, due to funding, etc. But it's work in progress, but it's really important for us to establish this national variant database. The clinicians are happy with this setup, but they're also complaining that taking this written consent and have this conversation with the patient takes a lot of time. So it's slowing down, the number of patients they can see during the day, and that's of course a problem, and we're trying to figure out how to do this and educate more nurses, etc., that can actually take part in these hard conversations. Then it's also a problem that, after doing the whole genome sequencing, doing the analysis, and the response you give back to the patient is actually placed in the patient journal out there in the regions. So you can do like an ethical committee application, then you can get access to this data. But it's quite a complicated process, and it takes a long time to dig into each patient journal and get the results. So we need to work smarter again and make sure that these results can be accessed easier and faster. And then, of course, the clinical evidence. I mean, we have these 17 patient groups, and it's built on experiences from the world, and we have done literature review, etc., and we have looked into our own data, but we haven't been able to establish clinical evidence within each of these 17 patient groups yet. And it's of course quite complicated to make politicians allocate budget for something that you can't really prove. And then second step is the economic impact. So of course we all know that personalized medicine in the longer run will benefit because we'll be able to do prevention, etc. But if we don't have clear economic evidence, I mean, no one will allocate budget. So this is so important, and we're working on this. And then, of course, the sustainable financing. We have financing for until next year, but then we'll have to negotiate again and again and again. So it has to be stable and be an annual budget. Why is this so... Oh. So our recommendations to another country implementing personalized medicine strategies or developing personalized medicine strategies, first of all, work together at all levels. It's so important that researchers and clinicians talk the same language, have the same focus, but they need to talk together with the policymakers and the politicians, and it has to be both national, regional, even municipality level, so you make sure you all go in the same direction. And you can't do this without industry, most likely, because you need the funding, you need to have the industry engaged if you want to move this fast, I think. And then it's centralized as much as possible. This doesn't mean that you shouldn't involve everyone. It has to be a very inclusive governance, but the more you centralize, the easier it is to move forward fast. That's our experience. If you have 5 different regions or 54 different hospitals taking their own decision, it's really, really hard. So we need to put them together and centralize the decisions with all these participants. And then, of course, follow international best practice. I mean, build on what's already out there. Don't invent the wheel yourselves. Think smart. Do prevention. Do diagnostics. Do reuse of data in once. Don't just go for diagnostics and research as we did. Do prevention at the same time as well, because it's a low-hanging fruit. And then make sure you have access to the data. Collect this data, make sure you can use this and do analysis and research and look into the clinical evidence and economic impact and evaluate continuously. Because if you evaluate continuously, you don't do anything that doesn't make sense. You can just stop the projects if they don't really make a difference. And then take your time. I mean, people tend to want to push this really fast because it takes a lot, it's really complicated, so you should take your time. If you push and you do a lot of things too fast, then you're not able to do it smart. So take your time. We did it too fast in Denmark. And then the legislation and the agreements among the partners, they have to be very solid because it's really complicated and things happen all the time, misunderstandings, and people say, oh, no, you're supposed to pay, no, you're supposed to pay. So have solid agreements, and then, of course, sustainable financing in place. Thank you so much.
Thank you. Thank you very much, Lene, and I believe that was a perfect timing. When the time was running out, then you finished. Thank you very much. I believe a lot of ideas to discuss and a lot of questions, of course, also in the audience. We're going to take the questions during the panel discussion, so going through all the stories and then questioning. The next one, please welcome with applause, Sonata Jarmalaite, Deputy Director for Research and Development and Professor, the National Cancer Institute of Lithuania, Vilnius, and Vilnius University, Lithuania.
Hello, everyone. So my kind thanks for the invitation to this event. I hope you can learn something from Lithuania, despite that we are not so far in this way on personalized medicine. If
I could ask technicians to put the presentation on the screen down there. Yes. It's not there.
Okay. I'm coming from the field of oncology, and precision medicine is very important in this field, so I mainly will talk about the oncology field, and it listens for me good. So the situation in Lithuania, every year we diagnose around 17,000 of new cancer cases, register 8,000 of new cancer deaths. And our measures in oncology, they are not pretty good. Still, investments into health services are quite low, and it relates to quite poor survival rates in oncology. And as I see, Latvia is in the similar situation. And in our days, we know that precision oncology holds a strong promises to improve the situation, because a lot of analyses have shown that actually only innovative drugs coming to the clinics, to oncology clinics, they can improve survival rates. And the investments into the personalized oncology, to innovative diagnostics tools, it's the only way to improve the situation on survival of cancer. And the situation is that in Central and Eastern Europe, we have quite poor access to modern diagnostics, genetic diagnostics, and access to innovative drugs. It's calculated that only 1/3 of medicines available, innovative medicines available in oncology, are accessible in our countries. So what issues we are facing, what problems are there? So yeah, first of all, we don't have well-developed next generation sequencing infrastructures. We still have some issues with the legislation, and mainly with the governmental reimbursement of diagnostics and innovative treatment. And of course, the situation with data collection, sharing of data, digital health records, and so on. And the main thing probably is the communication, involvement of all stakeholders. That's the major topics which needs to be covered on our way to precision medicine. And of course, we need to build our ecosystem of personalized medicine. So as it was done in Lithuania, we had many rounds of similar meetings, many talks. And for me, it was a good time to go back and to look when we started. And from my information, we started in 2017. At the National Cancer Institute, we had so-called Oncologist Club, where we invited all stakeholders from government, patient organization, and other important participants, and there we started a discussion how to improve the access to innovative therapies, how to deal with the coverage of companion diagnostics tools, and so on. So those all long meetings and talks, they finalized it quite productive results, but actually, as you see from timeline, COVID happened, and our meetings later on, they became virtual. But now we started after COVID our activities in Parliament. Our government already started to listen for us, and in 2022, an so-called initiative group on personalized medicine was established, and we signed a memorandum on action in personalized medicine. And at the same year, we have first forum at Lithuanian Parliament, where our governmental bodies already listened to our talks, and first 2-year plan was issued there. As we understood our personalized medicine network as a network covering not only treatment, but also cancer research, education, a set of meetings were taking place in our Academy of Science. And finally, government decided that we need to have a feasibility study on personalized medicine situation in Lithuania. And this year, in the summer of this year, it was prepared, released, and will be presented in 2 weeks, again in the meeting in Parliament, which will take place in 25th of October. So from the talks, we moved to an active movement, and we think that we need a national strategy on personalized medicine, sustainable strategy covered with financial background. So how we built our infrastructure, it was built, of course, gradually through those years which I covered, and it was built in collaboration or connection with various European activities, and RRF funds were used there. So first of all, our clinical genomic infrastructure is under development, and we used RRF funds, 7.6 million of euros to establish next generation sequencing infrastructure in the major clinics of Lithuania. It will generate this VGS data for Million Genome project, but of course the infrastructure, knowledge and the data will be used in the clinic, and the infrastructure will remain for patient needs. Other important infrastructure for personalized medicine is biobanking. Here we have another support from government, close to 10 million euros, to build a biobank infrastructure in major clinics in Lithuania, and also some research institutes are involved in this network. And our major goal was to join European structure, BBMRI-ERIC, with our biobanking infrastructure. It's already functional and quite well suited for personalized medicine needs. And we, previous year, we became a full member of BBMRI-ERIC. And, And of course, the main goal here in personalized medicine is patient and improved access to personalized medicine drugs. So, as I told, the situation in Lithuania, it's not very good with the access to innovative treatment and testing, but from 2021, first companion diagnostics was covered by Health Insurance Fund. Next year, we got coverages for PAM50 test, which is predictive for breast cancer test, and we hope, actually we know that next year is a small oncopanel covered by health insurance funds are coming for the clinical needs. And during that time, we built a nice network also based on our collaboration with colleagues in European projects like Primrose and PCM for EU. Where Drup-like studies are, infrastructure for Drup-like studies is implemented under this network, and we built a nice collaborative network in Lithuania, and hope to start quite soon with this innovative clinical trial. And of course, as I told, research in personalized medicine is very important to have a solid base for personalized medicine. And when we talk with our government, they say, yes, we have a lot of finances and tools, and every researcher which works in personalized medicine can find something suitable for him. But actually, we want a dedicated fund, longitudinal financing, sustainable financing, for our personalized medicine research, but truly we had several investments from Research Council of Lithuania into our networks, into our personalized medicine studies, which were quite fragmented, and we have a promise from them that quite soon we will have a longitudinal specifically dedicated to personalized medicine program, a national program for research in personalized medicine. Luckily, during this period in 2022, Future Biomedicine Charity Foundation appeared in Lithuania, and it already invested several millions into the small research on personalized medicine, also supported strong groups working on personalized medicine, and some awards were also provided by this foundation. And education. Education still is an issue in Lithuania, and here is 3 years ago I made a questionnaire for the patients, and when we ask, do you know what it is, personalized or precision medicine, only 20% of them responded that yes, we know. But when we ask about targeted treatment in oncology, do they know? Yes, 70% said yes, we know. So they know about testing, about what is close to them. But of course, they still don't have a wide understanding why this treatment is okay for one patient and not perfect for another. So this meeting, which we will have in our parliament 2 weeks later, also is a beginning of Personalized Medicine Academy. We will combine our efforts to teach our patients together with our major patient organization, POLA, and we have a plan to have a strong teaching network for our professionals. We have a promise from ESMO that next year we will have the Best of ESMO 2025, which will start our education of our clinicians in the field of personalized medicine. So a lot of challenges still remain, but we are working, consolidating our efforts, and I wish the best for the Latvian forum in order that they can move to personalized medicine as fast as all Europe moves. So many thanks to you, and this nice pictures was made by artificial intelligence and of course with the help of my PhD students. Thank you so much.
Thank you. Thank you, Professor, so much, and I believe thank you to artificial intelligence and my PhD students is a good combination for nowadays. Thank you very much, and we saw this incremental way how build up the strategies and perspectives, and we are absolutely happy to welcome on the stage with applause Mikaela Friedman, External Relations Officer, Genomic Medicine, Sweden. Welcome.
I'm very happy to be here, and thank you for the kind invitation to come here and talk. It's been a very fascinating morning, I think. My name is Mikaela Friedman. I'm External Relations Officer at Genomic Medicine Sweden. I'm based in Stockholm, Sweden, but we are a national covering initiative. So I would talk about I have the presentation there as well. Yeah, I would talk about the national implementation
Closer to the microphone.
of precision medicine in Swedish healthcare. I will stand still here. And as we heard this morning by the very moving patient story and by Stefan Pfister, we all understand why precision medicine is very important and necessary. It's already a transformation of healthcare. So we're moving from traditional medicine, where we give all patients the same treatment, into being able to subgroup patients and giving them different treatments, thereby having the right treatment to the right patients and having more effective treatment and reducing side effects as well. And as Stefan Pfister mentioned, to do this, to give the right treatment, it's very important with the precision diagnostics, the molecular diagnostics. So we are working very closely together with the Swedish research infrastructure, Science for Life Laboratory, SciLife Lab. Olli Kaljuniemi will come tomorrow and talk more about this initiative. They were started in 2010 and have quite a lot of activities into clinical genomics and precision medicine. So in 2013, discussions were started between SciLife Lab and healthcare professionals. How do we get these very advanced technologies into healthcare? And clinical genomics platforms were started and then started all over Sweden. And this was then transformed into what is Genomic Medicine Sweden today. So we have genomic medicine centers from up in the north and down to the south in the 7 healthcare regions with university hospitals. In Sweden, we have regional healthcare, so we have 21 different healthcare regions, but 7 of them are with university hospitals. So Genomic Medicine Sweden was started in 2017. This is just showing how we're working together a little bit more. We published a paper 2 years ago showing that SciLife Lab are doing discovery and testing and adapting the diagnostic tools, then are then taken over by Genomic Medicine Sweden to validate and implement into healthcare, and that is then going into routine clinical diagnostics. And we have complementary nodes all over Sweden to ensure this very tight collaboration. So Genomic Medicine Sweden is a bottom-up initiative, since we have this regional healthcare, and the initiative has come from the clinicians, from researchers, from diagnosticians to work together. So we're clinically focused already from the start, and we're implementing precision medicine. We're national, as I said, with these 7 genomic medicine centers. A lot of the work that we're doing is harmonization on standards, guidelines, method, both when it comes to diagnostic tools, bioinformatic pipelines, and so on. And this means that it's resource efficient as well. So we share the development, and as you know, there is a shortage of this very expert knowledge as well. And also we enable research and innovation from what we are developing. We're working in quite a few different diagnosis areas, so in rare diseases, cancer, microbiology, complex diseases, and pharmacogenomics. And our main aim is that all patients, regardless of healthcare region, should receive the best diagnostics and individually tailored care, treatment, and follow-up. And just coming back to a little bit about the organization, I realized that I didn't put in a slide on the organization, but Genomic Medicine Sweden is not a separate entity. We are the 7 university healthcare regions and the 7 medical universities. So it's healthcare and academia together. In our steering board, we have patient representatives, we have industry representatives, so we're working very closely together with them. And we also have an international advisory board, and now just started up an informatics advisory board also, because this is a very important part of the work that we're doing. So data is a very important part of these advanced technologies that we use for precision diagnostics. We have established a national resource, the National Genomics Platform, that is a data lake or high-performance computing cluster. That is a resource for healthcare research and innovation. It's a huge data lake that has a capacity of 4.5 petabytes of storage that the regions will use. And here we can also able to link genomic data to electronic health records and quality registries and other health data. Today, genomics data can be shared across the country within research projects that have ethical approval. So we are awaiting a legislation from the government to be able to do secondary use of data. We hope that this will come soon. So this is again showing the different diagnosis areas that we're working on. So in cancer, we have divided into hematology, solid tumors, and pediatric cancer. I know in the next room, my colleague Gustav Ljungman is talking about the GMS Childhood Cancer Project, and I will just mention this briefly. But then, of course, there are many other core infrastructures that needs to be in place as well. So informatics and data sharing, as I said, the ethical and legal part is very important. Communication and education that we heard from the previous speaker, health economy that Lene also was mentioning, and industry collaboration. So just to give you a few examples how precision medicine is already in the clinic. So whole genome sequencing in rare diseases has been done in Sweden for quite some years now. Last year, we sequenced more than 8,000 patient samples with whole genome sequencing in healthcare. And it's done at 4 of these genomic medicine centers, but they are taking in patients from all over the country. In this graph that shows a couple of years ago, a paper was published that by doing whole genome sequencing, an additional 40% of the patients can get a diagnosis, which is really important for these individuals with rare diseases. So we're also working on other projects such as long read and RNA sequencing, also in digital consent projects that is important to be able to allow for data to be shared, for example, within the 1+ Million Genome Initiative and other European collaborations. And we also started the Undiagnosed Diseases Network Sweden that is also funded by the Ministry of Health in Sweden. This is another example. We're working on blood cancer, hematological malignancies, where we both develop broad gene panels for subtypes of blood cancer, myeloid malignancies and lymphoid malignancies, and this is now being done in routine clinical care. And we also have developed whole genome, whole transcriptome sequencing. So just to show why this is important to be transformed into healthcare, we've done more than 580 pediatric and adult patients with acute leukemia with whole genome, whole transcriptome sequencing. And there you can see high concordance between standard of care and whole genome, whole transcriptome sequencing, but you also find more information. You also get more information, which means that you can risk stratify patient into subgroups compared to standard of care methods, which means that you can have other prognosis and other treatment options for these patient groups. We also done a microcosting study that was just published a few months ago, comparing whole genome sequencing to standard of care methods. It shows that whole genome sequencing is still more expensive, but the costs are coming down, especially reagent costs now are coming down, more newer instruments, but these instruments need to be effectively used. If they are, then within a year or so, we think that we can move from standard of care into whole genome sequencing for this patient group. This GMS childhood cancer is a very successful and unique pilot project that's been run in Sweden. So all children affected by cancer have been receiving whole genome sequencing, as well as what Stefan Pfister was mentioning earlier on, DNA methylation and also RNA sequencing. And this was started as a pilot project. From the first 800 patients, it showed that clinically relevant genetic alterations were detected in 91%, and for 24% of the patients, this could lead to potentially new targeted therapies. So a year ago, the Pediatric Association in Sweden was recommended whole genome sequencing as a routine test, and this has now been adopted by the healthcare regions as a routine test for all children in Sweden. We're also working with many other stakeholders, agencies in Sweden, Vision Zero Cancer, with healthcare and academia, to increase availability of clinical trials. So we're also part of this personalized medicine for all EU citizens and Primrose, these two separate EU projects, and there we're developing our own drug rediscovery protocol, this DROOP-like studies, the focus study. Another area that we're working in is infectious diseases. So doing gene sequencing is also important not only for cancer and rare diseases, but also to reduce spread of infection and monitor antibiotic resistance and so on. And here we're working a lot with the Public Health Agency in Sweden and also all of the microbiology laboratories around Sweden. So this is just showing from last year this pie chart that we did more than 90,000 clinical samples in healthcare with broad gene sequencing. Quite a lot in orange there is the SARS-CoV-2 sequencing, but there's also about 1/4 that is cancer gene panels and whole genome sequencing, and almost as much for rare diseases. It's very important with the international collaborations. We have quite a few bilateral agreements and collaborations with Denmark, with France, with Germany, and with UK on childhood cancer. And we're also involved in 1+ million genome. I'm not going to stick longer here since I see that time is running. But our experience is that it's very important to work on a national level, internationally, but also to work locally and regionally. So in Sweden, there are also, apart from the genomic medicine centers that we have set up, they're also now starting more precision medicine centers that are covering other aspects of the local regional part of healthcare. And it's a complex landscape. So there are many, we think it's very important to bring everybody on board and collaborate. We have this SciLife Lab research infrastructure. We have other program on data-driven life science that Olli Kaljuniemi will talk about more tomorrow. We have the biobanks. We have this precision medicine centers network. So we need to come together to work on this. And there we have a life science strategy in Sweden since a couple of years ago, where precision medicine is pointed out as a very important area. We have regions have produced their precision medicine strategy now just a week ago. So the healthcare regions from these 7 university healthcare regions, the healthcare directors there have initiated and coordinating now to put forward a roadmap for precision medicine nationally in Sweden. And this is also being met by an announcement from, you have the Minister of Health there in green, that they are funding additionally precision medicine, or now the wording in Sweden is precision health. That is a new buzzword. With additional funding for the next coming 5 years, which is a really positive thing. We're updating our 10-year strategy to meet everything that is happening in this field. And these are some important lessons and the way forward. So we, as I said, very important with this collaboration on all levels. And for us as a regional healthcare system to have this strategic partnership between the state and the healthcare regions and get in place a national infrastructure for precision medicine that has a true mandate from the government. The data sharing and secondary use of data is not possible today, so we hope we have had a governmental investigation, and we hope that this will be in place very soon. And continue developing technologies together with, for example, SciLife Labs, so we get more multimodal diagnostics into clinic and also clinical decision support tools. Investments, financing, of course, that needs to be long-term and sustainable. And as mentioned before, the need to educate profession, patients, and society. Thank you. I was right on time.
Thank you very much, Mikaela, and I believe a lot of lessons to be learned in a very detailed matter. For instance, the wording, how you call things, that's precision health instead of precision medicine. There is a huge philosophy behind that, I believe, and we're going to discuss that in a panel discussion, because politics always is about wording, including. Thank you. The next speaker of ours is joining us online through Zoom, and we welcome here in the audience with applause Arnon Afek, who is Associate Director General from Sheba Medical Center and Acting Director of Sheba General Hospital from Israel. And Arnon, do you hear us well, and are you online?
Yes, I can hear you. So I will try to share my presentation with you. And before that, I will thank you very much for the opportunity to be with you. I was planning to be personally with you, but unfortunately, Baltic Air canceled its flights to Israel, so we'll be in Zoom. But I do hope as soon as possible to join you and to see and to be together there in your really remarkable and very, very nice country. So with few seconds, let me share my presentation with you here, and you will tell me if you can see it. Do you see my presentation? Do you see it?
Many slides in the left side, which is
do you see the presentation?
Yes, maybe you could put the full screen. Yes.
Yes, I will put the full screen, please. Do you see it right now?
It's okay in this frame. Yes, it's okay. Thank you. The floor is yours. And
one second, let's see if I pass the presentation. It passes the pages.
No
No. My suggestion first is to put it this way and to show it in that way, because many times that's the way it passes the slides. Do you see it now?
Now it moves. It's okay now. Yeah.
Yes. So we'll do that. But if there's two different sources, then please close one down so I can speak and there'll be no echoing. Now it's okay. It's okay with you?
And also with the picture. Yes.
Is it okay with you?
Now it's not okay. Now we don't hear you.
You don't hear us.
And now
Because I hear. Do you hear me now?
we can hear you now.
All right. So let's start. So thank you very much for the opportunity to be with you and to share with you my presentation. My name is Professor Arnon Afek, and I'm the Associate Director General of Sheba Medical Center, as well as the founding dean of a new medical school, Edina Rekanati, at Reichman University. During my presentation, I will speak with you a little bit about what precision medicine is as a pathologist. I think it's very, very important to understand what is the shift in the diagnosis and in the way we pathologists and physicians think, and why it's so important to have a precision medicine. I'll say a few words about my medical center, Sheba Medical Center, and describe to you what we are doing here at Sheba Medical Center, one of the leading hospitals in the world, in the field of precision medicine. So when we speak about diseases, the classical disease is in fact whatever deviation from the normal structure and function, which carries therapeutic and prognostic significance. Now, if a certain therapeutics to a disease carries by 10 or 15%, we should not ask ourselves why we don't have the right treatments and whether we define correctly the disease. And when we, as pathologists, describe a disease, we describe the morphology, the differentiation, the way we see it through H&E and the different markers we use. But again, that's the way we define it. And in order for that to have a significance, it's also the clinicians that have to describe it. What do I mean? That if, for example, the oncologists need to know the HER2/neu status of our diagnosis of BRCA or EGFR, then for the diagnosis should include this component in order to be correct, because otherwise just saying that invasive ductal carcinoma, which has no meaning for the treatments and almost such a wide spectrum of prognosis, then it's not good enough. Therefore, if I sum up this slide, the definition of disease must be based on therapeutic and prognostic significance, and we, as pathologists, should include it in our diagnosis. And that's exactly why today we might give treatments to 100% of the patient with all the side effects, with the huge financial expenses, and end up with just 40% response. It means that we did not define right the disease. Therefore, if you will tailor-made the disease and give the right diagnosis with all its components, therefore we might reach a better response, less side effects, and public health cost significance. It might cost less money because we will not give very expensive biological drugs to people. It doesn't benefit them at all. So if having that in mind, what is the true significance of precision medicine? Let's say a few words about my hospital. So Sheba Medical Center was established more than 70 years ago. It's the leading teaching and academic medical center in Israel, and it's also the largest hospital in Israel. Just to give you a few facts, we have more than 10,000 employees, out of which almost 1,800 physicians, almost 2 million annual visits a year. The happiest part is that we have more than 11,000 births a year, the most complicated surgeries in Israel. Now, for the, 1 second, sorry. For the last 5 years, Sheba Medical Center has been ranked by Newsweek, the leading American journal, as one of the world's best 10 hospitals. And also this year, we were ranked also one of the world 10 smartest hospitals in the world. And many of our departments are in the world best specialized hospitals list of leading departments. So having such a large medical center, academic center, research center, innovation center, we launched a very comprehensive precision medicine plan at Sheba Medical Center. And with your permission, I will give you just few very fast examples of what we are doing at Sheba. So the first issue we are doing is adapting the treatment to the patient by its genetic profile. This is an article led by, it's a multi-center study led by Professor Talia Golan from Sheba Medical Center. She's the head of our pancreatic cancer center, looking for the BRCA mutation in pancreatic cancer, and being able to pick up these patients. It's about 7% of the metastatic pancreatic cancer patients. We have, it's a well-known leading example of adapting the right treatment to the patient. Tamir, for example, has already survived almost 10 years after being diagnosed with metastatic pancreatic cancer. But this is giving the right drug to the right patient. But you have to be even more creative by designating the drug to the patient. It might be that a drug does not exist. For example, in cases of diseases that we can use RNA and create an antisense oligonucleotide, for example, in diseases which has overexpression of mutated genes. And this article from Sheba Medical Center by Dr. Dominicini and Professor Rechavi, for example, which was published in Nature, showed exactly when you design the right drug to the patient, you can lead to huge improvements in the clinical outcomes. So this is the idea of antisense technology in order, in many ways, decrease production of harmful protein. It is a very significant approach, specifically in genetic mutations, whether reborn or afterwards, when you have one of the genes which being affected, and you can direct exactly the precision medicine approach to this gene's expression. So here you can see a tailor-made antisense oligonucleotide to a patient to Batten disease. It's a very, very rare disease. It's a neurodegenerative disease. And there is a significant decrease in seizure because the expression of his mutated gene was decreased by this treatment. And we are still conducting many treatments and trials in order to develop a specific treatment to a very rare and specific disease. But this is just one aspect. Itzhak Saidian is a PTSD patient who burned himself. He ended up with 98% burn. Now, such a patient would have normally died, but he is, by the way, very young patient. So we were able to use his own hair follicles. That was about the only keratinocytes that remained in order to grow in a lab the right his own skin and to implement him and to on him. It took us about 2 years to treat him, to rehabilitate him, and you can see here that such a huge team was needed to take care of one patient, and to grow, and a whole lab for a year was occupied in growing his own skin tissue, his own keratinocytes, and then putting it on him again. And that's for engineering the patient's own tissue. And this can be used in many other modalities, like taking, we have now an experiment run in Sheba to treat retinitis pigmentosa. It's a rare disease that causes blindness. And what we want to do is to personalize retina and to grow specifically and to differentiate retina cells in dishes in order to restore vision to such a patient. This is still under clinical trials at Sheba Medical Center, and we are very hopeful that we will find a treatment to this rare but really debilitating disease. TIL immunotherapy is used to treat melanoma cases. And what we do is we pick the patient's own T cells and we do to them immunomodification, immunomodulation by using the tumor cells and increasing the number of specific T lymphocytes directed, and using IL-2. So again, you pick up of the patient his own immune system, his own blood cells, white blood cells, you expose them to the tumor, you increase the number, you give them back in order to treat the patient himself. And here you can see the use of the TIL cells, how there is a decrease. Here you can see the tumor. You can see that the tumor disappeared in this metastasis. You can see the difference between this metastasis and the decrease in the metastasis. So you use for patients who otherwise would have been dead without this type of treatment. Now, the second advance was, of course, creating a defense CAR T cells, which is taking and creating a specific cell to take care of the patient on disease, redesigning the T cells. And here you can see the CAR T cell. We were part of the clinical trial of the CAR T cell done by Weizmann Institute, and we continue to treat lymphoma and leukemia, and now we are on clinical trial to treat melanoma and myeloma with such treatments. So this is the CAR T cell, and Israel is a large center for CAR T cell treatments. We have more than 420 patients who were treated with CAR T cells, and therefore. But what do you do when you have patients who do not have no treatment, who did not respond to treatment at all? How can you treat this patient? You check them out. I'm, as a pathologist, check them out, look for all their genetic makeup. We look for the drugs we have right now available or design their drug, and they don't respond. So what do you tell them from that time? They are designated to dead. There is a possibility to do the opposite way around, not to personalize the drug to the patient, to the right disease, to the right patient, but personalize the patient to the drug. Make the patient who did not respond to the drug respond to the drug. This is what we call reverse personalized medicine. And this is exactly what we are doing now at Sheba Medical Center in the most simple way even possible. And always the best solution are the most simple type of solution. So what was the idea? The idea was that to take patients who did not respond to drug, in this case PD-1, and take those patients who did not respond, because some of them did respond, some did not, go and pick up their microbiome, their gut flora of those who responded, pick these bacteria and give them to the patient who did not respond, having in mind the fact that maybe the microbiome can affect your response. And nothing is simpler than that. Just picking up the microbiome for patients who responded, taking the bacteria and multiplying it and giving it to the patient who did not respond, and re-giving them the same drug they did not respond there before. And what did we see? We see, not in every patient, but in many patients, we did see a remarkable response. Patients who did not respond when you gave them the microglia, the microbiome started to respond to these treatments. So here you can see pre-treatment and post-treatment in our patients. So if I want to conclude my very, very short presentation, I'm going to quote Albert Einstein, who said that we cannot solve our problems with the same thinking we use when we created them. We must think outside of the box. And the example of the microbiome is the simplest of what? What's more simple than picking up a microbiome, giving it to the patient who didn't respond in the past, and he starts to respond? So think always outside of the box. That's the idea of precision medicine in my point of view. And I do thank you again for the honor of being with you. I do hope that in the future I can be with you personally.
Professor? And indeed, you cannot see the audience, I believe, but during your presentation, a lot of cameras were out and making photos and notes. So thank you very much for very insightful presentation and a full scope. Thank you. Thank you very much, and applause one more time to Professor. Thank you. Now is the moment when we are switching over to panel discussion for those who are present. So I ask kindly to join the panel here in front, all our speakers who are present here. You want applause one more time, I understood, with applause. Lene, Cividanes, Sonata, Jarmalaite, please, with applause, yes. Mikaela, Friedman, yes, please. And joining here also our panel discussion is Professor Marcis Leja, Professor of Medicine, applause of course, Director of Institute of Clinical and Preventive Medicine, University of Latvia. And just the question, because the organization always for such huge events are happening like in the hills and valleys. Maybe there is someone representative from Ministry of Health, Madam Kaupere or Madam Janka. Maybe you're here, but I just don't see you. You're not here, I'm not seeing you in reality. Okay, then we continue our panel discussion here, and I will also sit here near the Professor Leja. And we opening our panel discussion in the way that at the beginning a commentary and reflection from Professor Leja, how we see precision medicine in Latvia with opportunities and challenges. And then we're going to start to take questions from the audience and dive deeper into a question on how to develop national strategies. Professor, please.
Thank you. And hopefully, yeah, now it is. Thank you for the kind introduction, and thanks indeed all the speakers. I think those were great experiences really to follow your experience, and starting from Professor Arnon Afek on really the examples how precision medicine could be applied to clinical medicine, very advanced clinical medicine, what has been demonstrated by the Sheba Center, and closer to our region, the experience what we learned from Nordic countries, from our neighbors in Lithuania. I think that was really very valuable, just because I believe many of us have been comparing the situation to the issues what we are facing in Latvia, and definitely a lot of those aspects have been considered. And we do have also in the Rome people who have been behind developing the national genome database in Latvia, and I think experience quite a lot of those issues that you have been mentioning as well. And definitely we are facing also multiple issues currently still. For instance, it was very interesting to see that in respect to the legislation, that while in Latvia we are for a couple of years struggling on the law of secondary database, still in Sweden it is an issue, but in Lithuania it has been accepted. So really very exciting issues to compare. What was really interesting for me to hear that the initiative on the legislation and the ecosystem has been coming from the scientists, and the politicians have been following this in Denmark. So we would really wish that also in our countries scientists would be so powerful to suggest changes that are really taking place. And the same in respect to the pediatric or precision medicine in pediatric population. In Sweden, that all the Swedish universities and regions have very rapidly uptaken the recommendations that were coming from clinicians. So really this is a very well organized infrastructure, and particularly the governance that has been considered, and I think what you have been mentioning as well was very important aspects on the terminology. Really, precision health should be the issue. Maybe we or the term that we use as well. Similarly to reverse precision medicine, what has been demonstrated from Sheba Center. So I think we indeed have a lot of things to learn from each other, and I think we are continuing to do this. After the lunch break, we will be having here a local session on how we proceed with the precision medicine ecostructure just here in Latvia, but without networks it also is not working properly, so we need to build those networks, in particular in oncology. And just to use a moment to mention that we are very strongly supporting the idea of building the network of cancer centers in the Nordic and Baltic region, and we are happy that we are going to have the next meeting during December. It will take place in Riga on December 2nd, so I believe that also people from the region would come and join. So that is my brief comment, but I think we could discuss much more on the topic. Thank you.
Thank you, Professor Leja. Now I have prepared my own questions as a moderator, but before that, showing also the deep and live interest of the audience, maybe we have some question in the audience considering the matter. Yes, wonderful. I will deliver a microphone.
Hello. Not sure. Yeah. Hello, my name is Ines Čakstiņa-Dzērve. I'm from Riga Danish University. I'm actually the cell person. And I'm going to be chairing the next session of functional precision medicine. And when we are talking also about the terminology, the precision medicine very often is taken, and what I saw from almost all the presentations here, we are talking only about the genomics. However, I would say that we have to be, while the genomics are of course the king and queen for the diagnostics, I would be a little bit careful with the treatment because there was this NCI match clinical trial and the publication last year in Nature Medicine showing that genomic for the, and especially saying in Denmark, you have like about 6,000 patients who have like this advanced cancer and incurable cancer, yes. So, and this showed that for these very hard cases, the genomics needs some help. So, and I know that in Sweden, actually, I've heard Olli's speech 2 weeks ago about like, that you have like gathering so many data points, but what's the benefits for the patients out of this like huge amount of the information from the whole genome sequencing? So maybe you can give your insights on like how do you look for the future for the precision medicine? Do you see some implementation of the functional tests into the clinical practice as well? Because that's what we are, well, at least I am in Latvia, are trying to move forward also. Not to diminish the genomics, but like kind of to comprehend and to help with the better treatment choices. Thank you.
Thank you.
You're absolutely, it's absolutely true. And I think this is showing how genomics is the first omics that is coming into the clinics, and that needs, imaging is already there in some part, and that needs to be followed by other omics technologies. We're just starting what is called now the PROMIS in Sweden, that is multi-omics national research initiative, but there's a lot of work being done at the Science for Life laboratory. That's why I think it's very important to combine like what you already have perhaps as research infrastructure, medical university, together with the clinicians and develop and moving things across into the clinic. But we also hear from other people that the genomics in clinic is already solved. In some parts it's there and it's working really well, but there are many more things to be done as well. So I think we need to continue pushing genomics into the clinic more broadly, but also follow up with other omics technologies. Yeah.
Okay, thank you. Any other comment on this?
I only can strongly agree with that. For sure, we need to invest into functional analysis and to speed up those studies in order to give answers for the patient as fast as possible.
Thank you. Yep, also a comment?
Yeah, I think from the Danish perspective, it was really important for us to push the whole genomes in as a beginning, because instead of doing like the small analysis, it was easier if you all from the beginning do the whole genomes and you have them in the genome database, and then you can access them again and again and again. So you have them, and then you have to be able to combine that. That's also why I had this very busy slide with all the registries. So we want to be able to combine with all kind of data, because not only for research, it's often talked about registries for research, but if the clinicians can actually get access to all data points on one specific patient, it's so much easier to do the diagnosis in the future.
Yep.
If I'm allowed to extend a bit the question, because what you have been mentioning also in your presentation of reusing the data again and again, so how you are dealing with the broad consent-related issues, and whether you manage to do this in the clinics, in the population, to reuse the data once more?
So from the Danish perspective, we have a very long tradition for collecting data. So all data, samples, everything has been collected for many years. We started out in 1960, and then we've built up more and more registries. And the population has a very big trust in the Danish registries. So they trust that when they give that data, it's protected and it's only used for research or for purpose related to themselves, so patients like me. So when you do a whole genome sequencing, for example, in the Danish system, well, you do the consent, you have to consent that the data will be stored in the genome database and it can be used for research. You can actually not say no to this. Then afterwards, when you've done your whole genome sequencing, it's done, you got your own result back or your diagnosis or whatever, then you can actually say, okay, I want to opt out. The data will stay in the genome database, but it cannot be used for research. But it's almost no one who does that. It's like 2% or something. We have when cases come up, and it also happens in Denmark that the data has been misused, not the genome data yet, but other data. And then of course some people do opt out, but it's very few people. So in general, people trust it, and they actually insist on that data being used for research and help other patients.
Well, logical question would be, but I believe that's a different conference, full day, maybe full week, how to build trust because you started to build it in the 1960s already, but still we are living in windy times on information and disinformation. So how, maybe one quick clue how you build trust during this?
I would say transparency. So it's really important to do extremely transparent and educate the population. So it's been a big thing also when we started the Genome Center to engage with the population and educate the population. So we've tried to, this has to be built into medical education, of course, but also, to primary and secondary education. You need to understand what is genomes and what is personalized medicine, because of course, I agree, personalized medicine is so much more than genomes.
Thank you. Any other comment? Okay, then we can go. The microphone is passing by. Okay, we can take one more question from audience, if there is such. Yes, please. I will go with the microphone to you.
Hello, everyone. We are representing clinical research, Icon company. We would like to know if you are ready for electronic informed consent, which is starting soon. You know that ICHGCP is updated. The final draft is coming in mid-October, so now. And we will be able to use electronic informed consents. It means videos for subjects, signing electronically, even remotely. Are you building these databases in your countries?
Thank you.
I showed very briefly the digital consent project that we're doing for rare diseases. So that is one project that is up now, testing how this can be done electronically, and I think that we will then need to push this into other areas as well. So it started, but we need to continue the work.
Any other comment?
Yeah, we are also talking about that, but actually Lithuania is a little bit different situation with this wide consent and with all infrastructure we started quite recently. So we started everything from the scratch, and GDPR was in the place. And I was recently visiting our colleagues in Curie Institute in Paris, and they told me, we have this all patient trust. It's very good health service there, and they have a huge collection, let's say, of oval melanoma. But actually, it was done. All this collection was made before the GDPR, and actually, it's now useless. So actually, yeah, we are going to this new direction, this electronic agreement, and so on. But we still need to think about our old collections, which are also very useful.
The times before GDPR. Here was a commentary for Professor Leja, and then you, okay?
Yeah, probably in respect to the historic data, that should be the secondary data use legislation that could allow using those data. But in respect to Latvia, so this is a practice currently already in certain academic studies, including also the dynamic consent, not too much in clinical studies so far, but probably it's coming. Thanks.
Yes, we are currently collecting the consents on paper as well, and Denmark is a very digitalized country, so people are asking for this, of course. And we just launched a project in Denmark. I'm saying someone just launched a project in Denmark where they're collecting the consents digitally for research, and we are discussing and looking into how this can be put into the clinical side as well.
Okay, thank you. We have some 3 to 5 minutes to discuss more, and focusing back and narrowing back to the title of this panel session, Developing National Strategies. Maybe from each of you, a short recommendation, and I will use the wording of Lene. You said that you have a feeling that you did that too fast, too quickly in Denmark. So the question about timing and the proper things in the proper time, your recommendation, and maybe for Latvia then, and that's going to continue after lunch break, of course. Your recommendation, how properly build national strategies or leveling the same level like plan or something like this, what not to do too fast, what is the proper order from your perspective, and your recommendation. Let's start with Lene.
Yes, I think the strategy was very timely in Denmark, and we did have time. But what happened in Denmark is that we were really lucky. We got a major funding from a private foundation. So we kind of aimed at doing this really fast, because with a lot of money you can do things faster, of course, but we kind of forgot maybe that it takes a really long time to do all the agreements among the partners, among the regions who had to share the data. So we looked often to the UK and say, wow, they were so lucky they did the 100,000 project, where they did research for like 5 years, I think, before they started implementing in the clinic. And often we dreamt about being able to do that, because then we would have time to build up everything in a slower pace. So I think it's important to have agreements in place among the partners and have everyone involved in developing the project or the strategy, and take the time you need. Don't rush yourself, because it's just gonna get back to you in the end.
Okay, thank you.
Yeah, I agree. Involve all stakeholders from the start. So, I mean, medical professionals, the clinician, bioinformaticians, diagnosticians, representatives from industry, from authorities, and not the least, patient advocates. So it's really important to have patient in the forefront, in the center, and the clinical need. And then to have the national strategy that should come with some sort of action plan and a budget, so it's really possible to act on it. And agreements, really important. I mean, for us as a regionally steered healthcare, to have this partnership between regions and the state, this is perhaps it's not the same here, but to have these agreements. So for us to have agreements between the medical universities and the regions, how should data be able to be shared, and so on and so forth. So yes.
Thank you. Sonata.
So we are as small as Latvia, so I don't know, we haven't thought so strictly about the agreements actually, because 3 clinics already have NGS infrastructure and biobanks and so on. So, but truly ecosystem, to build ecosystem involving all stakeholders, it's very important. And to have a sustainability for your strategic plan, not dependent on political waves and so on. It's a main thing. And of course, very important education, especially of patients' education.
Thank you very much. And Professor Leja, you have a wonderful possibility to conclude this session and make a bridge for the next one. Yeah.
Professor Afek also has something to add.
Oh, okay. Sorry, Professor Leja. Do you hear us? Professor, yeah? The floor is yours now. We know that you want to add something.
The only comment I wanted to say about what was said before, that absolutely right. Genomics is just part of the concept of treatment disease and definition of diseases, as I tried to state. And now we are not speaking anymore about just genomics, but on what we call omics. So omics is, of course, genomics, but also genomics is partly RNA and DNA and so on. Then we speak also about proteinomics, which are important. And we speak about metabolomic. And we are trying to create a whole data and to find out at the end what is relevant for a specific disease at a specific phase, and to see that the development of these all omics will be an ongoing process. So a patient will come with a serious, of course, disease, whether genetic, cancer, or so on, will start is with a definition, and all the time it will be evaluated, and the treatments will be adapted to his overall omics. And through the research we are conducting through, in fact, AI, because we will need for such used information, a very, very sophisticated tools, will be able to tell at the end what is significant and what is not significant for this specific patient.
And we are wrapping up here. Professor Leja, please.
Thank you. I cannot agree more on what has been said already. Maybe we can add still also a microbiome. Actually, within a couple of hours from now, it will be a regular meeting of the Million Microbiome from Human Consortium that is led by Karolinska, and Denmark is very actively involved in this. So indeed, I think we need to be broad on this. We maybe indeed need to consider in the terminology the personalized personalized health instead of medicine. And actually what I believe is really very important, the strategy, the governance, and definitely funding as well. I'm not sure that we will be so lucky as Denmark has been with having a great sponsor funding, although we are definitely benefiting of our local sponsors as well. So thank you, and I think we continue discussion then after the lunch.
Thank you. Round of applause. Thank you very much.